41-year-old female by name Sambal, who is hailing from Vishakhapatnam, Andhra Pradesh, who is a homemaker by occupation, who has completed her formal education till second PUC. She was admitted on 3rd of this month and examined yesterday. She came with complaints of bilateral pedal edema, facial puffiness, and decreased urine output and shortness of breath on exertion since the 3rd week of July. Patient was apparently normal 1 month back when she noticed swelling of bilateral lower limbs, sudden in onset, initially localized around the ankle region, gradually progressed over a period of 1 week to the mid shin. She also noticed facial puffiness during the same time. She also reported that she had decreased urine output in terms that her frequency of urination decreased from 4 to 5 times a day to 1 to 2 times per day in last 1 week. She also complained of shortness of breath on exertion. There is no history of during the same time there is no history of hematuria, dysuria or froth in urine. There is no history of decreased appetite, nocturia. There is no history of sore throat, cough, or any skin lesions prior to the symptom onset. There is no history of headache, nausea, vomiting, or blurring of vision. There is no history of any NSAID use or alternate medicine use. There is no history of orthopnea, PND, or chest pain. There is no history of any nasal discharge, epistaxis, or any asthma-like symptoms in the past. There is no history of any flank pain. There is no history of multiple joint pains, rashes, or photosensitivity. In view of these complaints, patient visited a private hospital in Vishakhapatnam. There few blood and urine tests were done, and she was informed to have renal failure. And her husband records that her creatinine was 8.6. They advised dialysis, and a right AJV dialysis catheter was secured, and she received 3 sessions of hemodialysis on 3 alternate days. During the stay in the hospital, there was no history of any blood transfusion. After she completed 3 sessions of hemodialysis, she was told that she will require a renal biopsy. Patient was shifted to the procedure room for renal biopsy in the private hospital, where she developed sudden onset shortness of breath, cough with expectoration, and minimal hemoptysis. She was immediately shifted to ICU and was kept on oxygen support. The attendants were informed that she had a high blood pressure and she was treated for the same. And once the patient stabilized and was on off O2, and she was referred to a higher center NIMS for further management. At admission at NIMS on 3rd of August, she underwent repeat blood investigations and other tests. She received a 1 session of hemodialysis in view of her decreased urine output and high creatinine, and she was posted for renal biopsy. She underwent renal biopsy on 2nd day of admission, and on the 3rd day she was informed that she had a severe form of renal disease for which she might require a special dialysis, probably plasmapheresis. On day 4 of admission, she received 1 session of specialized dialysis, that is Flex, followed by HD, which she tolerated well. On the next day, she developed shortness of breath, cough with expectoration, and hemoptysis. She was immediately shifted to ICU, where she was immediately put on intubated and put on mechanical ventilator. While on mechanical ventilator, patient received 1 session of plasmapheresis with hemodialysis, and she was on ventilator for 36 to 48 hours. Later she was extubated and was put on oxygen support. Post extubation, she underwent a HRCT and was informed to have some minimal lung infections, and she was started on antibiotics for the same. Later patient was afebrile, her shortness of breath decreased. Meanwhile, she received 3 sessions of special dialysis on 3 alternate days, followed by hemodialysis. Presently, she has been in ward. She only complains of decreased urine output, and she is dependent on hemodialysis, and she is complaining of decreased appetite and minimal pedal edema. Coming to past history, she is a known case of hypothyroid since 7 years, and she tells that she is taking Tacthyronorm.
Before going on to the past, her current status while she is still in the hospital,
Sir, she's stable.
When was the last session of?
Yesterday, sir. She received her last sessions of plasmapheresis on 16th of August, followed by hemodialysis. She is presently stable in ward, off oxygen. She's only complaining of decreased urine output and decreased appetite. She tells around 500 ml, ma'am.
Anything relevant in the present history you would like to convey, positive or negative findings?
Anything else found?
You asked about the skin rash or
Yes, sir. Initially only. Yes. There's no issue of multiple joint pains, rash or photosensitivity, no issue of flank pain, no issue of fever.
This is access for dialysis.
Right age only. The present which was kept in the outside hospital. Past history, she is a known case of hypothyroid for since 7 years. She is taking Thyronorm 50 mg since then. There is no history of bronchial asthma, tuberculosis, diabetes, hypertension, any history of any surgeries, stone disease, or seizures, or any cardiac or neurological ailment. Personal history, she takes a mixed diet. Appetite, presently she reports decreased. Urine output is decreased. Sleep is adequate. There are no habits. Her menstrual cycle, she reports normal regular cycles. Husband is a smoker. Family history, she is a third born to a non-cancerous married couple. No significant history of any renal disease in the family. Father is a hypertensive. She is married since 10 years. She had one abortion 1 year post marriage, which occurred less than 3 months after having found to her pregnant. She has no children since then. Drug history, she is on Thyronorm.
Summarize your findings.
A 30-year-old young female who is an hypothyroid since 7 years, married for 10 years with one history of abortion, no live children, spontaneous abortion, less than 3 months post detection of pregnancy, came with a short history of short 7 days to 10 days history of
1 month history. With total
initial
duration.
she came with complaints of pedal edema, facial puffiness, decreased urine output, and SOP, for which she was evaluated, found to have a renal dysfunction with create of 8.
Dialysis requiring renal failure.
She required dialysis required renal failure, following which she underwent a biopsy, which was informed to her to have a severe form of renal disease, and she underwent total of 5 sessions of plasmapheresis followed by hemodialysis, during which she had a 2-day history of mechanical ventilator support in view of severe shortness of breath.
There is no history of hemoptysis yet.
One episode of
After
hemoptysis.
presentation to NIMS, she had an episode of cough, expectoration, and hemoptysis. That time she was intubated.
So your
What are the possibilities in this? Syndromic diagnosis
Syn-
first and then the possibilities.
Syndromic diagnosis, I would like to place it as RPRF, RPGN, a anti-GBM chrysantic glomerulonephritis, or post-human renal limited vasculitis, and last human complex glomerulonephritis with hypertension and hypothyroid.
You kept anti-GBM first. Why?
I would like to keep post-human ANCA vasculitis first, sir,
First, why?
because
I agree with your opinion.
Not change your
no, sir.
What you change?
Yeah, so clinically she had hemoptysis, cough, hemoptysis, and rapid onset renal failures.
Yes.
But when we see the treatment aspect, initially she was informed to her dialysis dependent renal failure with a create of 8.6. Once presentation to NIMS, she was addressed renal plasmapheresis.
Your points.
So that is the strongest argument, in my opinion, in favor of anti-GBM disease. Why? I'll tell you why. Why not ANCA? In ANCA vasculitis, there is still a big controversy. The debate. We won't say that plasmapheresis is rejected or is obsolete. It may still be considered, but may be considered, that's all. Use that term.
Yes.
It's not a standard therapy. Whereas for anti-GBM disease, it is the standard therapy. So that's why I agreed with your keeping that as number one. Okay.
Which
Yes.
trial looked into the role of plasma exchange in ANCA-associated vasculitis?
Yes, ma'am.
Which trial?
Two trials, ma'am.
Because it
One
was
is,
still plus minus and
MEPEX
controversial.
and Plexivos.
Mhm.
MEPEX found that plasmapheresis was beneficial, but Plexivos didn't show any benefits.
Which was the larger trial?
Plexivos.
Pexivos, it is not Plexi, Pexivos.
Even MEPEX, the initial study showed benefit, but when those patients were followed up for a longer period of time, then the benefit disappeared.
As of now, what are the indications for Plex in ANCA-associated vasculitis?
Create of
What is the indication
For plasma exchange.
pulmonary hemorrhage,
Okay.
alveolar hemorrhage,
Mm.
yes, rapidly progressive renal failure with a create of greater than 5.6 representation.
5.4 as of the current KDIGO. Hmm. And one more.
CNS.
Can you have a double positive
Double
disease?
pos- Yes, ma'am.
So associated anti-GBM. These are the three indications for plasma exchange as of now.
So your final diagnosis is RPRN, RPGN,
Yes, ma'am.
anti-GBM.
I would think of anti-GBM. Second is Fossman crescent
Other
glomerulonephritis.
causes of hemoptysis in a patient with that.
Pulmonary edema, any associated lung infections can have hemoptysis.
You heard of pulmonary renal syndrome?
Yes, sir.
What is that?
Anything, even RPRF with pulmonary edema can present with hemoptysis or any severe lung infection like Klebsiella pneumonia with sepsis AKI can have.
Is it necessary that patient should have RPRF in the kidney to call it as a pulmonary renal syndrome?
No.
Anything combination of respiratory plus
Plus
kidney
respiratory.
disease.
That's a loose definition of pulmonary renal.
Yes.
There was a more rigid definition earlier, but now it's used for so many things.
Yes.
It can be pulmonary renal, it can be renopulmonary.
Yes.
Are you interested to see her?
How will you evaluate it? What other tests will you order?
Yes. Basic lab routines will be done. We'll get an anti-GBM titers, ANA by IF and ELISA. ANCA by IF and ELISA, ANA, C3, C4, DSD and anti-Smith. ANA by ANA by IF, ANCA by IF and ELISA. Yes.
Can you qualify that further? What is the current recommendation regarding ANCA testing?
ELISA. ELISA based testing, it should be
Qualify, can you qualify that ANCA further?
And yeah, what type of
You will
ANCA?
add any suffix?
MPO or PR3 ANCA.
Yeah.
Why?
What was the earlier term that used to be used?
C ANCA and P ANCA, sir. So there was a lot of overlap between the different ANCA vasculitis, maybe
C and P
MPA,
were
GP.
identified by what method?
IF, immunofluorescence.
Yes.
If there was a cytoplasmic staining, then it's called cytoplasm. Then if it's a perinuclear staining, that is called P ANCA.
Yeah, so that is now obsolete. So you said ANCA by IF and ELISA. That is what you first said. So leave out the IF now. Don't mention it IF any longer. It was the earlier. Now you have highly sensitive ELISAs. And you look specifically for PR3 or MPO, not for the IF pattern. So that's the important
Which is more
change.
common in our country?
MP ANCA.
Then will you suspect an anti-GBM disease clinically when a patient presents with an RPGN?
Patient will have a rapid onset progressive renal failure.
RPGN, already qualified as RPGN.
Any cough with hemoptysis, respiratory symptoms, shortness
with
of breath,
hemoptysis, agreed. One.
anemia.
Two,
Anemia.
disproportionate
And
anemia. These are the two situations where you suspect an anti-GBM disease. And can you have, why there is no hemoptysis in a subgroup of patients?
Because microalveolar hemorrhages will be there, which are not large enough to produce an
So how can you
hemoptysis.
identify a concealed alveolar hemorrhage?
DLCO will help us the most.
What do you mean
sensitive
by
test.
DLCO?
Diffusion capacitor carbon monoxide.
What is the?
Because hemoglobin will be denatured in the lung, which will
Huh?
observe hemoglobin, the blood which is exuded in the alveolar will get denatured, and there will be hemoglobin which absorbs the carbon monoxide.
Okay.
So the carbon DLCO is
Exhaled air
increased.
will not have any carbon monoxide, completely absorbed by the hemoglobin. Okay. Any other test to confirm that there is alveolar hemorrhage?
We can do a BAL, ma'am.
What will you look for?
Hemofiltrin laden macrophage.
Macrophages, okay. Now, can you have anti-GBM disease without an anti-GBM antibody titer?
Yes, ma'am. It can.
How will you explain?
A sync phenomena when all the anti-GBM antibodies are absorbed into the kidney in the initial part when there is extensive disease.
Any other explanation for anti-GBM antibody negativity? Which is the gold standard for diagnosis, isn't it, as of now?
Some anti-GBM.
What are the antigens against which these antibodies are produced?
The
Usually.
carboxyterminal of alpha-3 chain.
Mm.
Some antibodies are against the alpha-1 and alpha-5 antibodies, which are not
Antibodies
detected
may be
by
directed
the
against other
other
antigens,
antigens and
other than
elastin.
C3 domain. So again, you will not have this one. Okay. Now, what are the risk factors for anti-GBM? Anything else in the history you want to ask for?
Any exposure to smoking, hydrocarbon
Why
exposure.
smokers have
in
more risk of developing anti-GBM?
Ma'am, the basement membrane in the lung is concealed. It is a cryptic antigen. When smoking or any other injury which exposes the antigens will predispose to lung injury.
Okay.
Be it an infection or
So
pulmonary
smokers
edema,
more
or
chance
smokers or
of food
hydrocarbon
pastors
exposure.
disease. Then
Smoking, hydrocarbon
any
exposure,
specific job or working pattern?
silica exposure.
Exposure to silica also have some lung injury. Now, what will be a typical histopathological appearance if you do a biopsy for this patient? If this is anti-GBM,
Crescentic glomerulonephritis, ma'am.
qualify for the typical means more than 80% of this will be the biopsy report.
Usually around 90% of the biopsies will have crescents, and 70%
90% of
90% of the patients whom anti-GBM is positive will have crescents, ma'am. And in that
100% will have crescents.
and 70% will have more than 50% crescents in the biopsy.
So more than 80, what is the type of crescents?
Monomorphic crescents. All crescents will be in the same phase of the disease because
Usually
it's a one hit.
cellular or fibron.
Cellular crescents.
So you do biopsy in the early phase of the disease itself.
Cellular.
So 90% of the glomeruli will show cellular crescents. That is the classical picture.
They are all of the same.
Same.
What are the other features? What will be the glomerular capillary tuft?
It will be completely collapsed, ma'am. It will be-
Completely collapsed.
There might be
Cellularity of the tuft.
some increase in mesangial cellularity will be there, ma'am. On-
Cellularity is near normal. Near normal.
Increased cellularity is a feature of
Immune complex
Immune complex.
and capillary.
Category 2, class 2.
And there will be break in the basement membrane. There is exocapillary
You said
prospection,
crescents.
crescents. And other
Tubulointerstitium.
there may be some depending on the severity of the crescents, it might have some interstitial edema and interstitial
Acute
inflammation.
interstitial edema and
Definitely.
inflammation. That's all.
Sometimes
Vessels normal.
cells will be
Mm.
18 can
I
Antigen, it is mainly initially cell-mediated, antibody-mediated, sir. And later the cell-mediated immunity comes into place, where there is infiltration of the macrophages along with proliferation of the parietal epithelial cells, leading
Formed by
Cell is
what
formed by
cells?
what?
mainly parietal epithelial cells, sir, along with infiltration of macrophages. If there is in crescentic glomerulonephritis, there will be rupture of the basement membrane. So there will be the ratio of macrophages to epithelial cells will be more in anti-GBM, but the ratio of the breaks will be less in immune complex. So the ratio of macrophages to epithelial cells will be lesser in immune complex glomerulonephritis.
And there can be Bowman capsule gaps also besides the
Immunofluorescence,
Linear IgG staining. There can be C3 staining also.
which subgroup of IgG is more common?
IgG4. G.
IgG1.
Because the other conditions.
Other lead is for linear deposition.
Linear deposition, diabetics can have one. Cadaveric transplants. Cadaveric transplant post Alport syndrome. Alport syndrome patient have febrile glomerulonephritis.
Any MPGN variant?
Yes.
MPGN variant?
Fibrillary glomerulonephritis can have.
Fibrillary, yeah.
Fibrillary can.
But the non-renal indications for plasma
Yes, anti-GBM.
non-renal
Na-
indications.
non-renal indications
Or plasma.
for plasma exchange.
Yes. Lung hemorrhage, alveolar.
Other associated with renal disease.
Other diseases outside the kidney.
CNS vasculitis. Sleepers.
Urologists do plasma exchange for some other.
GBS.
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 And other renal indications for plasma exchange.
PMA,
EMA,
ABMR, ABMR,
ABMR, in transplant, anything else?
desensitization,
Desensitization, yes.
ABM compatible.
Compatible. Recurrent
FHS recurrence.
catastrophic APLA. How frequently should you do plasma exchange? Say in an medium.
Sir, it is advised to do every alternate day so that
Alternate day?
How much exchange?
In anti-GBM it is daily
Daily.
plasma exchange. Daily
Yes,
plasma
daily.
exchange.
Maybe difficult to do daily and particularly if you are doing hemodialysis also, but preferably.
40 to 50 ml per kg body weight of plasma exchange is usually advised according to training.
How many sessions are usually required?
7 sessions up to 14 days or until resolution of
Anti-GBM antibodies negative.
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 10 more other tests you give along with that?
Sir, we give pulse steroids and cyclophosphamide.
In which form?
According to KDU, oral is preferred, no? 2 mg per kg body weight.
What is the duration of immunosuppression for anti-GBM?
3 months to 6 months.
Why not you are giving maintenance therapy for an
Because it's an one-hit phenomenon, no? So relapse are very fast.
any other newer drug has been tried in anti-GBM?
Pledis, antibody like
What is imlifidase? What is it?
which lyses the antibodies.
Hmm? IDUS. What is the trial with IDUS in anti-GBM disease? Hmm? Udaidas.
Degrading enzyme obtained from IDES.
Any other disease where IDUS has been tried?
ABMR.
ABMR.
How long should you wait for the transplant?
6
What is
months.
the rate of recovery?
Patient survival is 8.
In other words, what are the risk factors? Prognostic bad, prognostic bad.
Most important, initial creatinine presentation. So higher the creatinine, more poorer the recovery. And dialysis dependency.
Yeah, that is important. Like this patient was already dialysis dependent by the time you got her. So the chances of recovery are not very high.
You are not recommending plasma exchange or immunosuppression if the patient is on dialysis.
How long should you wait before you decide on the transplant?
6 months now.
Anti-GBM titers,
Should be negative.
Negative.
recurrence post-transplant,
Less than 5%.
What is post-transplant anti-GBM disease?
It is mainly seen in patients of Alport syndrome who had received transplant.
Will they be positive for anti-GBM antibodies?
No, ma'am. It will be negative. The titers will be against the alpha fraction, so it won't get treated.
What percentage of Alport develop anti-GBM disease?
2 to 5%.
What is the fate of, if at all they develop anti-GBM?
The probably
Graft loss,
graft loss
50% graft loss.
what is the experimental body
for
for the anti-GBM? Have you heard of Massoudi apparatus?
Masudi, Steve Blake. Madam is very favor of experimental models, so be thorough with all models.
Old timers will be asking you those questions.
Madam is not knowing. Madam is not knowing.
I am the first category.
Why do you want to, whether he's a double positive or a,
Yeah.
this one? What is this
Double
relevance in
positive.
clinical setting?
double positive will require maintenance immunosuppression.
Okay.
Single positive.
What is the difference in prognosis of double positive versus isolated anti-GBM or ANCA?
Anti-GBM has the worst prognosis, followed by double positive, followed by ANCA positive.
In the initial phase of the disease, double positive has a poor prognosis, but long term you can give in maintenance immunosuppression and prognosis is better. And you have to give plex if there is double positivity. These are the two reasons.
Besides anti-GBM antibody, which are the other antibody-mediated kidney disease, renal disease, or glomerulonephritis?
IG, antibody immune complex. No.
Can you explain the antibody
Membranous
mediated
nephropathy,
disease?
anti-pleural antibodies.
Membranous, yes, that is the new addition to the list, which wasn't there earlier.
What about minimal change? Is there now?
Anti-nephrin antibodies.
10 minutes. We remove now. That will be our. So 5 sessions.
And the one which you already mentioned sometime back,
DNA, GBN and febrile glomerulonephritis.
that's not antibody, that's a marker.
Marker. And
But antibody-mediated glomerular disease, in the differential diagnosis you mentioned that. This patient. You said anti-GBM,
possible.
possible. So isn't that antibody-mediated?
Yes.
What is the antibody?
ANCA.
ANCA. Do we think that ANCA is pathogenic or not?
It's pathogen.
Most probably yes. There is evidence to support. So that's another antibody-mediated disease. And in membranous nephropathy, how many target antigens have been identified so far? Just to bother you.
You handle it day by day.
What
Which
are
is
some
the
of, what are
commonest
some
one?
of the, yeah.
Commonest one.
The commonest one is CLA2, followed by NEL, thrombospondin, CLA2R, PLA2R, NEL, thrombospondin, exhaustin.
ठीक है काफी